Okay, so I'm starting then. A very good morning to all of you all. I wish all of you all a very good morning. So what I'll do today, you are able to hear me, right? You are able to hear me?
Yes, we are
Can
hearing.
you see my slides also?
Yes.
Okay, then I'll start. See, yesterday I had done basics of oncology, which was divided in two parts where we saw all the aspects with respect to cancer, like what is cancer, what are the different causes of cancer, and why cancer arises in human body, what goes wrong, then a patient gets cancer. We saw all that. We also saw how cancer is classified, then what are the characteristics of cancer cells or malignant cells, then how a patient is staged and graded, because that helps in basically giving the and basically deciding the type of treatment which has to be given to the patient. Then which are the different types of diagnostic tests which are done for treating cancer, which are the imaging techniques which are used for treating cancer, for diagnosing cancer. We also saw what is biopsy. Then we also saw the tumor markers which are related to the various types of cancers. Then after seeing the classification of cancer, we also saw the different treatments which are given, and in that we basically have studied the chemotherapeutic drugs, how they are classified, what is their mode of action, and which are the drugs in each classification. We saw all that. Then we also saw what is the principle behind chemotherapeutic drugs, why we have chemotherapy regimens and protocols, how the body surface area is calculated, and why do we have cycles in chemotherapy. Then we also saw the different types of side effects associated with chemotherapy. And lastly, we saw the different types of studies which are done when a product or a combination is gets approved. We also saw the different types of study designs, right? So we have studied all this. So and after that, of course, Ajay has taken a couple of products, so I'm sure you have understood all that. Today, after completing the training, we will send you all the recording. We will send you all the slides also. So you can go through it anytime you all have any doubts, queries, you all can come back to us, right? So now I'll start a product called Imatinate, which is basically imatinib mesylate. And this product is for CML, that is chronic myeloid leukemia. That's a hemat indication. And it is also used for a solid tumor called as gastrointestinal tumor. Okay, so I will study about CML in brief. Only we'll study whatever is required. And we will also study GIST, and then how they are treated with imatinib. We see that, and then after that there are a few more indications associated with imatinib. We'll go through that also, right? Basically, first you want to study CML, but if you have to study CML, we have to understand what is leukemia. Basically, CML is a type of leukemia. The full form of CML is chronic myeloid leukemia. Yeah, so it's a type of leukemia. But what exactly is leukemia? Leukemia is a type of blood cancer where there is uncontrolled proliferation of WBC or leukocytes. WBC is also called as leukocytes. What do you mean by uncontrolled proliferation? When you have when the WBCs grow huge in number, which cannot be controlled. Okay, proliferation is multiplication of cells. So multiplication of WBCs is uncontrolled, which is beyond control. Then a condition called leukemia arises, which is a type of blood cancer. But when these cells, these WBCs, which are multiplying in a very fast manner, which cannot be controlled, when they become abnormal, then obviously a condition called leukemia arises. Okay. So basically in leukemia, basically leukemia is a type of blood cancer where there is uncontrolled growth of WBCs, which are also called as leukocytes, and these WBCs, they become abnormal and they are large in number, therefore leukemia arises, right? But in leukemia also you have a lot of classifications. We'll see that also. Leukemia can be classified as acute or chronic. What do you mean by acute? Acute is something which starts suddenly. Chronic is something which progresses gradually and takes very long time. Yeah. And then they are also classified on the basis of the type of cells which are involved. If lymphoid cells are involved, then it is lymphoid leukemia. If myeloid cells are involved, then it is myeloid leukemia. Okay, so there are two types of, they can be divided in two types, that is acute chronic and lymphoid myeloid. Now, I have already explained you acute means rapid onset. That means it starts suddenly. This is a fast multiplying leukemia and it is fatal if it is not treated immediately because it is multiplying very fast. Then you have chronic, which takes months and years to progress. Monitoring the disease may be an option before treatment. You have to first monitor the disease, see how it is progressing, and then give the treatment. And it is a slow moving and a slow progressing type of cancer. Lymphoid, I told you, if lymphoid cells are affected, then it is called as lymphoid leukemia. If myeloid cells are affected, it is myeloid leukemia. Now you have to combine the two. If in acute case myeloid cells are involved, then it is acute myeloid leukemia. But if in the acute case lymphoid cells are involved, then it is acute lymphocytic leukemia. In chronic, if myeloid cells are involved, then it is chronic myeloid leukemia, that is CML, and today we will be studying about CML. If in chronic lymphoid cells are involved, then it is chronic lymphocytic leukemia. Therefore, basically leukemias can be classified into four types: acute myeloid leukemia, acute lymphocytic leukemia, chronic myeloid leukemia, and chronic lymphocytic leukemia. Yeah, so these are the four major types of leukemia. And the short form is ALL, AML, CLL, and CML. And today we'll be studying about CML only. Now I told you acute means rapid progressing. So mostly affects the cells that are not fully developed or differentiated. Here it is fast multiplying. Yesterday I had explained you what you mean by differentiation. So when differentiation starts, then the cells are poorly differentiated, right? So these cells can multiply fast. In acute leukemia, you have cells which are not fully developed and differentiated. Therefore, acute leukemias multiply very fast. These immature cells cannot carry out their normal functions. They cannot carry out their normal functions, therefore they behave haywire and then cause destruction. In chronic leukemia, it progresses slowly, permits the growth of greater number of more developed cells. Here you will see abnormal cells, but they are still developed, right? If they are developed, then obviously they will not multiply very fast. Therefore, it is a slow moving tumor and multiplies slowly. These mature cells can carry out some of their normal functions. So they are carrying out some of the normal functions, plus they are also carrying out the abnormal functions. Therefore, it is a slow moving tumor and the damage caused by chronic leukemias is comparatively lesser than the acute leukemia. So what is CML? CML, that is chronic myeloid leukemia, we saw here chronic means it is progressing slowly, myeloid cells are involved, and this is a disease of the adult. So generally it is seen in the age groups which are like above 60 years. Chronic progresses slowly, myeloid affects the myeloid cells. What are the signs and symptoms of this disease? Your patients will have easy bleeding, patients will get tired, will have fever, frequent infections, unexplained weight loss, sometimes loss of appetite. They can also feel pain or fullness beyond the ribs on the left side because there you have the bones which have bone marrow. Okay, so because of that, they can feel the pain. Skin gets pale. There can be excessive sweating during sleep. So these are some of the common signs and symptoms of CML. Now, what is the cause of CML? Why do patients get CML? Basically, it is because of a chromosome abnormality. Here, what happens? There is reciprocal translocation between chromosome 9 and chromosome 2. Okay, I'll show you in the diagram, which results in a longer chromosome 9 and shorter chromosome 22. The latter, that means chromosome 22, which is formed and which is shorter, is called as Philadelphia chromosome and it is designated as PH. And this chromosome, Philadelphia chromosome or PH chromosome, is responsible for causing CML. So here what happens is, before translocation, you have the chromosome 9, you have the chromosome 22. It has the gene ABL, it has the gene BCR. So there is reciprocal translocation between the two genes. Therefore, with translocation, there will be a chromosome 9, which is long, a chromosome 22, which will be shorter, and the ABL gene and the BCR gene both come in this small new gene which is formed in the new chromosome which is formed, which is called as Philadelphia chromosome. So it has BCR gene and the ABL gene. So it is BCR ABL gene which are present in the Philadelphia chromosome. And this new Philadelphia chromosome, which is shorter and which is formed, is responsible for causing CML. Okay, so the patient who is suffering from CML, here the concentration of PH chromosome or Philadelphia chromosome will be on a higher side. Philadelphia chromosome creates a new gene, we saw that is the BCR-ABL gene. The BCR-ABL gene contains instructions that tell the abnormal blood cell to produce too much of an enzyme called tyrosine kinase. So this new BCR-ABL gene which is formed, which is a part of the abnormal blood cell, they produce too much of an enzyme called tyrosine kinase enzyme. And this tyrosine kinase enzyme promotes cancer by allowing certain blood cells to grow out of control. In the presence of tyrosine kinase enzyme, the cell's multiplication is very fast. So why you will have multiplication of WBCs? Because the BCR-ABL gene is there. BCR-ABL gene gives instructions to produce too much of tyrosine kinase, right? So when too much of tyrosine kinase is there, and this enzyme is responsible for the growth and multiplication of cells. So with this huge number of tyrosine kinase, the production of the abnormal WBCs is on a higher side. Okay, therefore you will see the abnormal WBCs are on higher side, and all of them will have this BCR-ABL gene, which will in turn mean that they will have the PH chromosome, that is a Philadelphia chromosome. So what is the main thing that we understand? That the tyrosine kinase, which is getting produced on a higher concentration, we need to control that, right? That is, tyrosine kinase is also called as TKI, is called as TK, tyrosine kinase, right? Now, we saw what is Philadelphia chromosome and why a patient gets basically CML because of this Philadelphia chromosome. And Philadelphia chromosome, what does it do? It in turn makes tyrosine kinase in huge numbers, which is responsible for the huge cell production, or a huge number of abnormal WBCs are produced, right? But let us just understand, and then we will again touch upon the Philadelphia chromosome later on. Now let's understand the different phases of CML. CML has got three phases, as it is a chronic leukemia. That means it will multiply slowly and gradually. It will last for a long number of years. Chronic phase, which is the initial phase, will last for 2 to 6 years. Okay, so the chronic phase generally lasts for 2 to 6 years. So maybe initially the patients may even not come to know that they are suffering from CML. So if it is in this stage, it is easy to treat. Then in the accelerated phase, which will last for 1 to 1.5 years, and the blast crisis will last for 3 to 6 months, which is the last stage and a difficult stage to treat. Now, in leukemias, and especially CML, we have to understand some terminologies. Like yesterday, I have explained you all the different efficacy parameters like response rate, your overall survival, progression-free survival, and disease-free survival, right? But that was with respect to solid tumors. When it comes to hemat tumors or blood cancers, there you monitor the efficacy in slightly different manner. Okay, in CML, it is when we talk about partial hematological response, it means there is 50% reduction in WBC count from baseline maintained for at least 2 weeks. So what do you mean by partial hematologic response? After the treatment is given, the patient's WBC counts come to 50% from the baseline. That means when the treatment was started, if the WBC counts were X, then when they reduce by 50%, they become X by 2. Okay, and when they become X by 2, and if they are maintained for 2 weeks, if this 50% reduction, if it is maintained for 2 weeks, then we say there is partial hematological response. Now, what do you mean by complete hematological response? This is defined as a reduction in WBC to less than 10,000 cells per cubic millimeter cube, and platelet counts are 450,000 per cubic millimeter, and this is maintained for 4 weeks. So then it is called as complete hematological response. WBC counts 10,000, platelets will be 4.5 lakhs per millimeter cube, which is maintained for 4 weeks. So that situation is called as complete hematological response. Okay. There are certain cytogenic responses. These were hematological response, and this is cytogenic response. What do you mean by cytogenic response? We will see whether there is presence of Philadelphia chromosome or there is absence of Philadelphia chromosome. Right. So here, complete when there is yes, one second. So cytogenic response complete when there are no cells that are pH positive. Complete cytogenic response means the Philadelphia chromosomes is totally not there. Okay, so that is complete response. Then you have partial response when 1 to 35% of cells are positive for the for PH chromosome or Philadelphia chromosome. So in partial response, 1 to 35% of cells will have Philadelphia chromosome. And when you talk about minor cytogenic response, there 36 to 65% of cells will still have Philadelphia chromosome. And when it is absent, when over 65% of cells are positive for Philadelphia chromosome. Yeah. So this is what you mean by cytogenic response. We have molecular response. In what do you mean by complete molecular response? That is BCR-ABL transcripts are not detectable. Complete molecular response means the BCR-ABL transcript or the BCR-ABL gene is not detected. That means it is not present. The abnormal gene which is present in the Philadelphia chromosome, if it is not there, then it is called as complete molecular response. And when BCR-ABL transcripts or this gene is present in 0.1%, then it is called as major molecular response. If it is completely not there, then it is complete molecular response. If there is presence of BCR-ABL gene, which is at 0.1% level also, then it is major molecular response. Okay, so this is what you mean by the different efficacy parameters. One is the hematological response or hematological efficacy parameters. You have cytogenic efficacy parameters, and you have molecular based cytogenic response or efficacy parameters. Now, what happened? We saw the different terminologies which will be used when we monitor the disease. But how the patients were treated with CML? In the olden days, the treatment for CML was busulfan, which is an alkylating agent, and it causes hematological response in 75% of the cases. So causes hematological response in 75% of cases. So what do you mean by hematological response? We just saw it is the WBC counts and the platelet counts get reduced. Okay, so that was seen in busulfan patients who have taken busulfan, right? Then PH chromosome is not eliminated. By giving busulfan, hematological response was there in 75% of the patients, but PH chromosome was still present. PH chromosome is not eliminated. That means the chromosome, which is the main cause of CML, that is still present even after patients take busulfan. Considerable hematologic side effects. So this busulfan had some of the hematological side effects. Therefore, its role is limited. It did give hematologic response, but chromosome PH chromosome was not eliminated. So the use of busulfan was very, very limited. Then came this hydroxyurea molecule, which we have and which you have seen yesterday. KDAB has also got hydroxyurea and the brand name is riburia. This hydroxyurea inhibits DNA synthesis and it also repairs the damaged DNA. It is associated with hematological side effects. It has GI related toxicity. It has some of the skin related side effects also, and this hydroxyurea also does not eliminate Philadelphia chromosome. But this is an economical drug, therefore generally given in government institutions and for the poor patients also. Yeah. Does not cause it does not eliminate the Philadelphia chromosome. Therefore, the requirements were not met with hydroxyurea also. It was only associated with it was only inhibiting the DNA synthesis, right? And it had a couple of side effects and it was not eliminating the Philadelphia chromosome also. So there was a need of new treatment. Then came interferons. It causes reversal of Philadelphia chromosome. The Philadelphia chromosomes do reduce in number, but it was expensive treatment. It had hematological toxicities. It has got allergic reactions. Plus, it is given subcutaneously, so it is a painful product also, right? Therefore, it was not preferred. Plus, patients had to come to hospital to take the treatment. It was expensive, plus patients had to get admitted and take the treatment. Therefore, it is a tedious procedure. Therefore, again, this product didn't meet the requirement. Then after that came imatinib, and it was found it is used to treat CML and GIST. Yeah, so chronic myeloid leukemia and GIST is called gastrointestinal stromal tumors. I will explain you that. It is the first member of a class of agents that act by inhibiting particular tyrosine kinase enzymes instead of non-specifically inhibiting rapidly dividing cells. So the advantage of imatinib was pinpoint. It was inhibiting the tyrosine kinase enzyme, which was actually responsible for making the abnormal cells. So imatinib had a very pinpoint and a targeted approach. Therefore, it was preferred. It belongs to targeted therapy. It was identified in the late 1990s, and this product was originally launched by Novartis, and the original brand was Gleevec. Today, imatinib has become the gold standard treatment for treating CML. Imatinib mesylate, chemical name was STI 571, is a compound which inhibits BCR-ABL oncoprotein, which is pathogenic in CML. So it inhibits the BCR-ABL oncoprotein or the oncogene, which is responsible for CML. Imatinib fits into the active site of the BCR-ABL protein and prevents ATP from binding. See, if any gene has to phosphorylate, if any substrate has to phosphorylate, then the ATP molecule is required. But what will imatinib do? It will go and attach itself to the VCR-ABL protein, and it will not allow the ATP to bind itself, like here. You have the VCR-ABL tyrosine kinase combination, and this is the substrate. So for phosphorylation, the ATP group, which is responsible for energy also, has to come and bind itself. Okay, so when ATP molecule comes and binds itself to the BCR-ABL tyrosine kinase, then the phosphorylation of the substrate takes place and the cell proliferation occurs. Altered cellular addition, abnormal proliferation will occur, and inhibition of apoptosis will also take place. But if you have this STI 571 is nothing but imatinib. If the imatinib is coming in attaching itself to the BCR-ABL tyrosine kinase gene, then the ATP will not come and bind itself. If they don't get ATP, then the phosphorylation of the substrate will not take place, and you will see altered cellular addition, abnormal proliferation, and inhibition of apoptosis. All this will not be there. Therefore, the cell proliferation will stop. The further multiplication of the abnormal WBCs will stop, and this is how imatinib acts. It goes and binds itself to the BCR-ABL gene, and it does not allow the ATP to come and bind itself. Therefore, the phosphorylation of the substrate does not take place, and therefore it controls the CML. Without ATP as a phosphate donor, the ABL protein cannot phosphorylate its substrate, thereby preventing the unchecked proliferation of leukemia cells. Can you see this?
Yes.
Yeah, the video. So here you'll see the BCR-ABL gene. This is a substrate. Okay. Then you have Gleevec, that is imatinib, which comes and binds to the site. Therefore, ATP is not able to attach itself, and this is how the cancerous growth is controlled. Okay, so this is how it is. Once again, substrate, the ATP molecule comes and binds. You have the imatinib coming and placing itself, therefore ATP cannot bind itself. So this is how Gleevec acts, or basically imatinib acts, right? So what are the indications of imatinib? It is used for newly diagnosed adult patients with Philadelphia chromosome, which are positive CML, that means PH positive, Philadelphia chromosome positive CML in the chronic phase. So basically, imatinib can be used for newly diagnosed patients who are in the chronic phase. What do you mean by the chronic phase? I showed you chronic phase is the first phase which will last for 2 to see chronic phase, which will last for 2 to 6 years. So your imatinib is approved and can be used for newly diagnosed patients. That means patients who are coming for the first time and who are in the chronic phase. So it is approved for those type of patients. And of course, they are pH positive patients. That means Philadelphia chromosome positive patients. So for newly diagnosed patients, it can be used. Patients with Philadelphia chromosome positive, which are in the blast crisis, accelerated phase, or in the CP phase, that means chronic phase, it can be used, but after the failure of interferon alpha. See, we saw first the treatment was busulfan, then came hydroxyurea, then came interferons, right? So today also interferons are used at times. So patients who have been put on interferon, but If there is a relapse or recurrence, if they are not able to tolerate, then for such patients, you can give imatinib after giving interferon also. But in all the three phases, in the blast crisis, accelerated phase, and chronic phase. In fact, chronic phase, accelerated phase, and blast crisis, in all the three phases, you can give imatinib after the use of even interferon alpha. And the third indication is it can be used for adult patients with relapsed or refractory pH positive, that means Philadelphia positive ALL. We saw that it can be used for CML, but imatinib also has its role in ALL, that is acute lymphocytic leukemia. What does acute means? Which is starting suddenly. Lymphocytic means the lymphoid cells are involved, right? But which type of ALL patients? The ALL patients who have pH positive chromosome. That means Philadelphia chromosome is present. So only in those patients imatinib will work. But in which a group of patients whose disease has a relapse or refractory. Relapse means has come back. Refractory means no other treatment is working. So you give imatinib. To such patients also imatinib can be given. Also, it can be used for adult patients who have undergone surgery and who have been detected with GIST. So GIST is nothing but gastrointestinal stromal tumor. It is a type of GI malignancy that which occurs in the GI tract. First and foremost, the treatment given is surgery, and post surgery, the patients are put on imatinib so that there is no recurrence or there is the disease does not progress, disease should not relapse. Okay, so these are the four important indications of imatinib. The dose, CML patients. Chronic phase, the recommended dose of imatinib is 400 mg per day, once a day. Okay, so the recommended dose is 400 mg daily for chronic phase. In the accelerated phase, that is the second phase, or even for the blast crisis, the dose is 600 mg per day. That means 600 mg is given once a day, and it is continued till the disease does not progress. Treatment is continued as long as the patient continues to get the benefit. Here, generally, patients take it for 2 to 5. There are studies where patients have taken imatinib for more than 10 years. It's a very, very safe drug. Okay, so this is all about CML and even the ALL indications and leukemia for that matter. Now we'll understand what is GIST, because that is a third indication for imatinib. GIST, as I told you, the full form is gastrointestinal stromal tumors. It's a very rare type of cancer. It's a type of sarcoma. 1% of all the GI cancers are GIST. Okay, all the different types of GI cancers that we see, in that only 1% is GIST. Now, what exactly is GIST? It occurs in the GI tract, which starts from the mouth till the large intestine. That is a GI tract where the food gets digested. We eat, we grind the food gets digested, then it gets absorbed in the complete GI tract. But it is most commonly seen in the stomach or in the small intestine region. It grows from a very specialized cells which are found in the GI tract called interstitial cells of Kajal, that is ICCs. So the type of cells which are involved are called as interstitial cells of Kajal. This GIST is found generally in the adults between the age of 40 to 70. They are very rarely seen in children and young adults. Now, GIST has got like your CML had got BCR-ABL gene in it. Here, GIST will have c-KIT protein. Okay, so it is c-KIT positive tumor. c-KIT is a protein also known as CD117 cell surface antigen, which is present in the GI tract. So this protein is present in the GI tract. When this protein is present in the GI tract, then the patients get GIST. Okay, so the presence of c-KIT protein in these abnormal cells is high. So basically you have to treat this c-KIT protein. There you are treating the BCR-ABL gene. Here we are treating the c-KIT protein. So c-KIT is a cell membrane receptor tyrosine kinase that binds to the growth factor stem cell factor, that is SCF. Binding to this SCF, c-KIT binds to SCF, which leads to structural changes in the normal KIT receptors, which triggers phosphorylation. This phosphorylation cell proliferation is initiated. So the c-KIT protein will attach itself to the growth factors and they will basically trigger the phosphorylation, and if phosphorylation is triggered, then cell proliferation takes place. So this is how what is happening in GIST. Take care of that. So the treatment options of GIST will be prime modality is surgery. First and foremost, surgery is done because it is in the GI tract, so you can remove the maximum portion of the GI tract and make the patient free of the disease, right? There are chances of recurrence even after surgery. So radiations are rarely used in GIST, but imatinib is used for treating GIST, but post-surgery. So what is the mode of action in GIST? Imatinib is an selective potent inhibitor of c-KIT positive tyrosine kinase. Like imatinib was a potent inhibitor of the tyrosine kinase in CML. Here it's a potent inhibitor of c-KIT positive tyrosine kinase. So it will go and inhibit the c-KIT positive tyrosine kinase. Then what happens? Imatinib blocks the ATP binding, preventing the substrate from phosphorylation. Obviously, it will prevent the phosphorylation like how it did in CML. This in turn will stop cancer cell proliferation, and this is how the control is kept and maintained, and because of which the abnormal cells will die. So this is a simple mode of action of imatinib. Imatinib is indicated for the treatment of adults with c-KIT positive and or metastatic malignant GIST. Okay, so basically, just 1 second. So just imatinib is indicated for the treatment of adults with c-KIT positive and metastatic or malignant GIST. So basically, if the patient is c-KIT positive, obviously patients have to be put on imatinib, and also patients who are in the metastatic state. That means if the disease has spread outside the GI tract, there also imatinib is used, right? So imatinib can be used for c-KIT positive patients and also for GIST patients whose disease has progressed and the disease has metastasized. The recommended initial dose of imatinib is 400 mg or 600 mg daily. We have got 400 mg capsules and we have got 100 mg capsules. So if the dose is 400 mg, then we flat 400 mg capsules can be given. But if the recommended dose is 600, then 400 plus 200 mg capsules are given for GIST. Okay, so the recommended initial dose could be 400 or 600 mg daily with treatment maintained as long as the patient continues to get the benefit. Till the time the patient is getting the benefit, imatinib is continued. It can be given beyond 2 years also in GIST. Okay. Some of the side effects associated with your imatinib, it is like very mild nausea, vomiting, diarrhea, edema, heartburn, headache, and muscle cramps, which are very mild. Therefore, patients can be put on long-term imatinib. And that's why you will see the CML patients also take imatinib for beyond 10 years also. Okay, therefore, the side effects which we see with GIST are very mild and minimalistic, and the severe, you say, side effects which are seen could be anemia, neutropenia, thrombocytopenia, which are common in the blast and the accelerated phase, and generally they are not common in the chronic phase. Chronic phase is the initial phase, so there it is not common, but in the accelerated phase, it is accelerated phase and blast phases. This side effect is generally seen. Okay, just one second. What are the advantages of imatinib? This product specially targets an enzyme in cancer cells and not the healthy cells. The advantage of imatinib is it's a targeted therapy. It will target only the tyrosine kinase enzymes or the you can say the c-KIT TKI the enzyme. Therefore, it has a very targeted approach, and that's why the normal cells are not harmed or damaged. Therefore, the side effects are very less. Minimal side effects as compared to other treatment given orally instead of injections. Whenever you have an oral drug or an oral preparation, it is always preferred because consuming is easier, and plus there is no hospitalization. Okay, patient can take it at home. The patient does not have to go and admit themselves in the hospital. So no admission, no hospitalization. That's why imatinib is preferred over the injectables. So this was about the advantages, about the side effects, the dosage and indications. To show you that there are certain guidelines which talk about the use of imatinib. See, there are various guidelines with respect to cancer, but worldwide there are multiples. But most of the doctors who follow the European and even the American data, all of them follow the NCCN guidelines. NCCN's full form is National Comprehensive Cancer Network. This is a body which runs in the US, which comes up with guidelines for all types of cancers every year. So every year it keeps updating the guidelines. Okay. So here they show that the drug interaction of TKIs, tyrosine kinase inhibitors, with most commonly used drugs and supplements. So when you are giving any of these TKIs, like imatinib is a TKI, it is a tyrosine kinase inhibitor. Similarly, you have bosutinib, dasatinib, nilotinib, vonatinib. All these products have also come for CML now, but they are generally combined with different proton pump inhibitors, histamine 2 receptors, with antacids, with antidepressants, and cardiovascular medications. So it was found when all these products combine and when imatinib combined, there are no major interaction. There are no major drug interactions with of imatinib with these classification of drugs. Like imatinib will have no major interaction with proton pump inhibitor, neither with histamine 2 receptor nor with antacid. So it can be freely given with all these three. It has minor increase in exposure or minor drug interaction with antidepressants, and if the exposure of imatinib is for a very prolonged time, it can have a slight interactions with cardiovascular type of medications. But with all the other molecule, if you see, they have got drug interactions with all of them. Therefore, giving imatinib is a safer option, right? Similarly, it can be easily given with anti-infectives, and it is generally avoided with herbal preparations, but with anti-infectives, it can be combined. Okay, and it will have no drug interaction. Whereas with all the other combinations, you will see some or the other drug interaction, and in some cases they are contraindicated also. Therefore, it's a safe drug. So, what are the USPs of imatinib? It's a potent, selective, and oral tyrosine kinase inhibitor. Potent because it's effective, selective, it attacks the tyrosine kinase inhibitor, plus it's a oral preparation. Significantly superior to interferon alpha plus cytarabine in newly diagnosed adult patients with CML. Less troublesome than the combination therapy of interferon and cytarabine. Why less cumbersome? Because it is an oral preparation, so no hospitalization, no admission. Patients can comfortably take it at their home. It's an important armamentarium for the treatment of CML in all the three phases. It can be given in CML for newly diagnosed patients and also in all the three phases. In the initial phase, chronic phase, in the accelerated phase, and also in the blast crisis. It is approved for the treatment of malignant, metastatic, and unresectable GIST. Okay, so it can be given in the GIST patients. We saw that it can be given in GIST after surgery, and that is in the adjuvant setting, and it can also be given in GIST in the metastatic stage if the disease has spread, and also the patients where surgery is not possible, unresectable GIST, there also imatinib can be given. So these are all the your approved indications and the USPs of imatinib. This is generally well tolerated. We saw there are no drug interactions, no major side effects. Administration is troublesome less. Significantly lower cost of therapy as compared to the initial brand. Our imatinib, definitely the cost is less of K-Lab's imatinib if you compare with the originator like Gleevec, you know, and plus it's an in-house good quality production. We are making it in-house. It's our own product. We are assured of our quality because from last 30 to 40 years we are producing oncology drugs. So doctors have got full faith and confidence in our quality, right? Composition imatinib 100 comes, it's a capsule. Each hard gelatin capsule contains imatinib mesylate, which is equivalent to imatinib 100 mg. Imatinib 400 is having hard gelatin capsules, and imatinib mesylate here is equivalent to imatinib 400 mg. Presentation, imatinib 100, it's available in 30 capsules bottle. Imatinib 400 is available in 30 capsules bottle. Why? Because the dose is 400 mg has to be taken on a daily basis. So one capsule per day. So the packing is 30, right? It has to be stored in a cool, dry place and protected from light. There are two more indications of imatinib which have come up recently. So I just thought I'll share with you. First, for the adult patients seen with aggressive systemic mastocytosis, which is called as ASM, aggressive systemic mastocytosis. These arise in the mast cells. Mast cells, if they become excess in number, then a condition called mastocytosis arises. And because of this, what happens? The organ systems most frequently which are affected because of increase in the mast cells are the bone marrow, skeletal system, liver, spleen, and the gastrointestinal tract. Okay, so you have huge number of mast cells which are abnormal, and they affect all these organ systems like bone marrow, skeletal system, liver, spleen, and GI tract. Therefore, it requires treatment, and the dose here is 100 mg per day to 400 mg per day. But this you will have to check in your areas whether the doctor is using, and these type of patients are coming. If you have aggressive systemic mastocytosis patients coming in, then of course you can promote imatinib. Then there's another indication called hypereosinophilic syndrome, that is HES. This is a type of blood disorder that occurs when you have high number of eosinophils. Eosinophils are also a type of WBCs which play an important role in our immune system. So if eosinophils are large in number and they are abnormal, then a condition called hypereosinophilic syndrome occurs. Over the time, the excess eosinophils enter various tissues and they eventually damage your organs. So if these eosinophils are huge in number and they are abnormal, they start entering the different tissues. When they start entering the different tissues, they damage the organs when they enter. So that is a condition which is not acceptable and requires treatment. And the dose here is 100 mg or 400 mg per day. That's why we have got 400 mg capsules and 100 mg capsules both. Yeah. So that's it with respect to Imatinate. This is a very interesting product, and I'm sure you will also enjoy selling the product, reading the product, and learning the product. It's a targeted therapy with a very cutthroat approach, and it acts on the tyrosine kinase inhibitor only, and pinpoint it kills the malignant cells only without affecting the normal cells. So that's the beauty of this product, right? So that's it from my side with respect to imatinib. If you have any doubts, please feel free to ask. Anyone has got any queries, any doubts? Yeah.
No, madam.
Sure, you've understood the product? Hello?
Yeah.
Sure, you have understood the product? All of you have understood? All of
Okay,
you
madam.
are comfortable with this product now? I can't hear you all.
Come again, madam.
Yeah? So
We
comfortable,
understand.
no queries, no doubts?
No doubt.
Okay. Okay, so we can continue with the next products?
Yeah.
Okay, just wait. Now Ajay will continue and I'll join later. I'll just call Ajay. Yeah.
Okay, thank you. Thank you.